My name's Omar Sinno. I am the U.S. Medical Strategy Lead for Rare Disease at UCB Pharma. Crowded market for sure, great for the patients. And I think one of the great things about this year, what we presented is, in addition to great data about Zilbrysq and Rystiggo, we also presented data on health equity and data about treatment guidance in the context of treatment goals for physicians. Where do we want them to get to go with their symptoms, pregnancy and family guidance as well. But on the Zilbrysq side, there are a couple of very interesting things. We have our auto-injector data. We really try to make sure that we're giving patients options. And I think that's one of the great things about the field right now. Lots of different options. We know in MG, all the patients are different. So we have the prefilled syringe for Zilbrysq, which has very good persistency data. And the auto-injector we studied, and Zilbrysq is a daily subcutaneous self-administered injection. The auto-injector has 99.8% bioavailability similar to the prefilled syringe. So that's one aspect. We also have very good data on minimal symptom expression with Zilbrysq, where about 62% of people, once they got to minimal symptom expression in the phase 3 open label extension, 80% stayed in minimal symptom expression. On the Rystiggo side, we have great data that shows consistency of response after the first cycle, and if there were some individuals that didn't respond very well, after the second cycle, there was consistency of response. So a lot of good data that shows both the clinical side. We also have very good healthcare resource utilization data. So yeah, a lot of good data to help physicians, understand the options, understand more about the medications now that we're a few years outside of launch, practical applications, subpopulations, and things like that. The time to diagnosis, it used to be a lot longer, 5 to 7 years. Now it's about 2 years, which is a lot better, still too long. But there are definitely a lot of disparities in rural versus more urban academic center. We have a lot of work, especially one of my colleagues, Judith Thompson, who does our population health, talking about those disparities. And especially in the African American community, there is diagnosis later, presentation with more severe symptoms. And so a lot of our work focuses on subpopulations that don't have good access to care, have poor outcomes. Judith Thompson did a food services program, given the importance of quality food in an auto-inflammatory disease. I think in a conference like this, sometimes the clinical data gets a little bit more attention. We have other venues to make sure that that information gets out. We were just at the Myasthenia Gravis Foundation of America patient conference in Fort Lauderdale. So that's a great venue. We make sure that we attend smaller advocacy events. But the reason we focus on that is because the symptomatology for MG, or really any disease, is very important. You don't want patients getting worse, going into exacerbation or crisis, but there is the other component of that. You need to make sure that overall, like you said, quality of life is getting better, satisfaction is getting better, and you want the patient to achieve their treatment goals. And this is, one of the papers that I mentioned that Dr. Narayanaswamy led, that we worked on, is the treatment guidance consensus, like I mentioned. And one of those goals is establishing treatment goals for the patient, getting a more understanding of guidance around the management of symptomatology, and in looking out for infections, looking out for vaccinations, family planning and pregnancy. So it really needs to be a comprehensive look at things and a comprehensive understanding and plan for the patient.